Hi, my name's Olivia Casey, and I'm the Senior Director of Programming for the Autoimmune Association. Earlier this year, by congressional mandate, the Office of Autoimmune Disease Research was stood up within the Office of Research of Women's Health. Before we take a closer look at the new office, what you need to know about it, and why you should care, let's give some context for its purpose. First, let's ask a few questions. How many people do you think have an autoimmune disease in the U.S.? 10 million? 20? 30? 50? 80 or more? We don't really know. All of those figures have been cited by different organizations as feasible. It depends on who you ask. What we do know: there is no central registry that collects this information, such as we have with cancer, so we extrapolate from other sources. There's little consensus on the numbers. What we do know from the sources we do have is that autoimmunity is on the rise. Incidence and prevalence are increasing. Let's clarify our terminology here. Incidence means the number of individuals who change from non-disease to disease state, or the occurrence of new cases in a single period of time, in this case a year. Prevalence is the proportion of the population living with the disease. From the data we do have, we know that both of these numbers are increasing. Here we can see some examples of around the world over recent decades. The estimates for the time periods are connected by lines to visualize trends. You may be thinking, well, it could be because we've improved diagnostics over the years, and that could be true in many cases. However, there is other research that indicates this is not the only reason. Another indicator is a demonstrable increase in anti-nuclear antibodies, or ANA. This is the most common biomarker of autoimmune conditions, which recent research has determined to be increasing. Now, to be clear, autoantibodies alone are not a diagnostic for disease, but they do define the presence of autoimmunity and are some of the best predictors of the development of autoimmune disease. Researchers used the National Health and Nutrition Examination Survey, or NHANES data, a CDC program of studies established in 1959, and they found the ANA prevalence was 11% from 1988 to 1991. Between 1999 and 2004, the prevalence increased to 11.5%, and then between 2011 and 2012, ANA spiked to 15.9%. Extrapolating those percentages would result in 22, 27, and 41 million Americans affected. Now, probably the most alarming ANA increase was among the young. Children and young adults ages 12 to 19 experienced nearly a threefold increase. These teenagers may well be subject to a lifetime of chronic illness. This research also displaces the theory that increased physician recognition of autoimmune diseases alone may be causing their apparent overall increase in numbers. Diagnostics are hopefully improving, but the underlying increase in numbers is still there. So given these increases, what type of numbers are we talking about? The Johns Hopkins website estimates that 10 million people suffer from autoimmune diseases. That's 3% of the entire U.S. population, with the caveat that they do not really know how many. According to the National Academies of Sciences, Engineering, and Medicine, known as the NASEM report, the last study that considered autoimmune diseases was published in 2009. This study estimated that the prevalence of autoimmune disease was 7.6 to 9.4%, or 25 to 31 million people today. However, this estimate was based on only 29 autoimmune diseases, and it does not account for increases in recent findings or emerging conditions. Let's compare the U.S. to Canada, where one study estimated that 16% of the Canadian population has at least one autoimmune disorder, which correlates with approximately 53 million people in the U.S. Now, in 2020, a researcher from the Autoimmune Association took 111 autoimmune conditions and pulled the NIH incidence and prevalence data, discounted for multiples, and came up with approximately 80 million patients with at least one autoimmune disease. This effort will by no means withstand scientific rigor, but it does indicate that there are many who suffer from autoimmunity that are uncounted for one or more diseases. We have had researchers concur that the number 80 million is not shocking, and indeed could be higher if all autoimmune-related conditions were taken into account. These are diagnosed patients, If we consider that there is an average of 4 to 4.5 year journey to diagnosis overall, we have exponentially more patients. They may not have a firm diagnosis, but they are suffering nonetheless. A recent NIH report states we are now experiencing an autoimmune epidemic, with current projections suggesting they will soon take their place among the predominant medical disorders affecting the population. The disparity is reflected in the totals reported by advocacy groups. We looked up the incidence and prevalence for the 11 autoimmune diseases listed in the NASM report. These are self-reported numbers by each of the attendant advocacy organizations or commonly accepted citations. If these numbers are accurate, even with multiple incidences, when we incorporate 150 plus autoimmune diseases, the total number of those affected by autoimmune disease is currently underestimated. While there are many factors impeding our overall understanding of the magnitude of the problem, we have no consensus definition, centralized data registry, overarching research strategy, or understanding of the overall cost of these diseases. It's difficult to measure what we can't define. There's no consensus regarding the boundaries of the definition of autoimmune, autoinflammatory, immune-mediated, or immunodeficient diseases. These terms are broad and used differently by different groups. Clinicians and investigators may consider autoimmune and autoinflammatory conditions similar and common enough to think of them as one entity or as two closely related entities. Physicians and clinical researchers classify autoimmune diseases according to symptoms and laboratory abnormalities. Now, basic science researchers classify autoimmune diseases according to more inclusive biological mechanisms. Recent scientific advances regarding cellular and molecular mechanisms of tissue injury have blurred the lines between autoimmune and autoinflammatory disease, making differentiation between the two very difficult. Diseases that science have not historically considered to be autoimmune, such as Parkinson's and cancer, have immune mechanisms. The result is we do not have a comprehensive definition or consensus vocabulary on what is and is not autoimmune. There is no mandatory reporting system or national registry for autoimmune diseases. Existing incidence and prevalence data often comes from other countries that have healthcare systems covering the entire population that may not distinguish sex and gender. The countries may not reflect our diversity and may be racially and socioeconomically homogeneous. They simply don't necessarily reflect the diversity from Miami to Detroit to Salt Lake City. Because of this, we have limited ability to assess trends. We also can't clearly identify the prevalence and incidence of under-researched autoimmune conditions, such as celiacs. And trend analysis is impeding. As an example, a study proved that the 10-year mortality rates in an incidence cohort of lupus in Georgia was 28% in Black persons and 9% in white persons. How does this correlate nationally? We don't know because we don't have a method of systematically collecting this information. Although not specifically tied to a registry, studies have demonstrated considerable underreporting of autoimmune diseases as the cause of death. It's difficult to quantify mortality in most autoimmune diseases since death more commonly results from, and is recorded as, being the result of complications such as cardiovascular disease, infection, or malignancy rather than a specific disease. Now, research requires data, and we currently lack long-term population-based epidemiology studies. These studies, over a time span of 20-plus years, would allow us to assess trends, risk factors, and costs that could help inform future research. The best guesstimate we have on the overall cost of autoimmune diseases can be extrapolated from 2001, when Dr. Anthony Fauci at the National Institutes of Allergy and Infectious Diseases, or NIAID, estimated that annual autoimmune disease treatment costs for 20 million autoimmune patients was greater than $100 billion, or roughly $168 billion in 2023 dollars. So for a reference, this is what we as a nation spend on the VA, the Department of Energy, and NASA combined. This is for 20 million patients. Imagine what it is like if it's 40 million, or 60, or 80. And these are direct costs. not the indirect burden of lost wages due to non-workforce participation or the intangible costs of pain and disability. Recent forecasts in 2022 indicate that number could be as high as $500 billion, which is about 2/3 of what we spend on Medicaid to take care of 30 to 80 million people. Now let's compare that to what we are spending on research. The NIH is the largest single funder of autoimmune disease research in the world. Currently, 13 of 27 institutes or centers, or ICs, undertake the majority of all autoimmune research in the U.S. Now here's a look from 2008 to 2020 of the total spent by NIH, which is not the only group investing in research, but certainly the largest single funder in the U.S. Now, let's compare how autoimmunity stacks up to the rest of NIH obligations. It's remained at approximately 2.8% since 2008. Effectively, it's been flat, despite the demonstrated increase in autoimmune numbers. And then there is the lack of strategic approach. Each IC has a different mission, sometimes overlapping, and frequently each has different research priorities and focuses on different autoimmune diseases than other ICs. The reporting formats are not standardized, nor do they indicate how they choose diseases. Some listed diseases are common, such as RA, a focus of NIAMS, and some are exceedingly rare, such as autoimmune encephalitis, a focus of NINDS. There is no comprehensive, transparent, and strategic approach as to how it plans and evaluates progress made on autoimmune disease research as a whole. The way the diseases are dispersed across the ICs may lead to a siloing effect, particularly if there's no systematic attempt to coordinate activities. What this tells us is that we have a looming crisis without meaningful intervention. This leads us to the OADR. In 2019, Congress charged the National Academies of Sciences, Engineering, and Medicine, known as NASEM, to prepare a report evaluating the current status of autoimmune disease research. The committee of researchers, clinicians, and scientists returned the report, which was a deep dive on the current state of autoimmunity. The report is a terrific and comprehensive analysis of the state of autoimmune disease research. While there were multiple solutions put forward, the winning recommendation called for the creation of the Office of Autoimmune Disease Research within the Office of the NIH Director. This was not a new recommendation, as it was originally proposed in a bill advanced by then-Senator Joe Biden in 1999. So last year, Congress directed $10 million to stand up the office within the Office of Research of Women's Health, or ORWH, which is located within the Office of the Director. The office is now in its infancy and working to establish a strategic plan. The website provides a great resource for autoimmune information, and here we can see the priorities that's defined by the organization. Now, this is not an easy task, and certainly one that will entail considerable time and resources. The instructions from the Senate Appropriations Committee contain this report language, but there is a role for patients and advocacy organizations, and we're excited by the opportunity to participate. We do have some next steps. We encourage the involvement of multiple stakeholder communities to help clarify and define consensus definitions that are relevant and make sense to everyone, clinicians, researchers, patients, and advocacy organizations, not just domestically, but globally as well. In order to establish our priorities, we need to know how many people are being affected and what those changes look like over time, as these priorities will help inform future research. There needs to be an effective master plan approach that coordinates efforts across ICs, which will lead to more efficient allocation of resources and promote research that is not redundant. And the cost. What little data we have now indicates the cost is increasing over time, but we need to have a better understanding as to how those funds are currently being spent, where they're being spent, and a strategy on how to effectively reduce the costs of healthcare. Recently, the Autoimmune Association, along with several other advocacy organizations, participated in a listening session where we shared our collective resources with the OADR leadership and offered our support for the nascent office. It's clear this is a patient-focused undertaking and one that will no doubt require time to become fully engaged. advocacy groups, and patients clearly have a role to play in making sure this is a successful undertaking. Make sure and check back on the resources section of the Autoimmune Association website for updates, or go directly to the OADR website. There's more to come. Thank you for your time.